been in practice for just over 20 years. And I've tended to always split my time between clinical practice and working in education. And then more recently, for the last few years, I've worked more in research. And this year I started as a research fellow for NCOR, the National Council for Osteopathic Research. And that was specifically with the purpose of developing something called a practice-based research network. And so I've been approaching all the different CPD groups around the country to try and explain to as many people as possible about the practice-based research network, what this means for osteopathy, why it's going to be really useful, really important, and how people can get involved. So that's what I'm going to be talking about today. If you've got any questions, please feel free to interrupt me if you want to. But I'll leave time at the end for questions as well if you want to write them down and come back to me towards the end. I will provide the presentation to Claire to distribute, and all the links should work in it as well. So don't feel you've got to write anything down that's on the presentation, as I'll share that. I'll share that afterwards. So. What is a PBRN? So I'll cover an overview of a PBRN, why I think it would be useful for osteopathy. This obviously links to evidence-based practice. So I'll provide an overview of that, of what that is, and the pros and cons around evidence-based practice, and the challenges that we've had as a profession. Then I'll go through some examples of clinically useful research and how accessing research can enhance clinical practice, and then how to get involved with the PBRN, and then any questions and your thoughts. We as NCOR are really interested on your thoughts to the PBRN, because ultimately it's going to be the profession that is involved in it. So what is a PBRN? Essentially, it's a group of practices or clinicians. You can be an individual clinician. You don't have to be part of a larger practice, that work together with a coordinating organisation that would typically be a university, but in this case, it will be NCOR alongside the University College of Osteopathy. NCOR is hosted by the UCO. And working in conjunction, we conduct research, or a PBRN conducts research that answers questions relevant to clinical practice. But where that might differ to traditional research is that with a PBRN, the research is actually being conducted by the clinicians in the clinical practices to which we're trying to inform. So, i.e., the research would be being conducted by osteopaths in their osteopathic clinics with their osteopathic patients. What this means is that the research that's produced is highly relevant to osteopathic practice or to the clinical setting it's conducted in, compared to the vast majority of clinical research, which is usually conducted in a secondary or tertiary setting, so in a hospital setting or a specialist clinical setting, where often the clinical interventions used, the treatments used, or the patients that are involved in the research aren't really representative of what we see in community-based clinics, particularly osteopathic clinics. So often there's a challenge in translating the research that's published or applying the research that's published to our own clinical practice, because the context it's been conducted in is just so different to how we see our patients. So that the aim of a PBRN is to actually conduct research in the setting that you're trying to apply it to make that research much more useful. So how would a PBRN benefit you as an osteopath and in your practice? Well, it provides real world evidence. So it's evidence that's going to have been derived from research conducted on patients very similar to yours, if not your own patients, if you're part of the PBRN, in clinical settings very similar to yours, and using treatments very similar to yours. It's also person-centered evidence, because the research is constructed around the patient. The patient is receiving the treatment as they will do in the real world, in the same clinic as they will do in the real world, So it means that it's much more relevant to the patient as well as to you, the clinician delivering the treatment. And it minimizes that translation that's required often when you read a research paper. You've got to start thinking, well, is this really relevant to my clinical practice because my patients are different? I don't really use that treatment very often. And, this was provided in a hospital, et cetera, et cetera. So it minimizes that translation that's required. Having evidence that's more relevant to your practice gives you more confidence because you can apply that research to your own clinical practice. So the decision-making process is better informed, giving you more confidence, and ultimately improving your patient care, which improves your patient satisfaction and just generally enhances clinical practice. Being part of the PBRN will inevitably mean that you will need some training in research. And so we will provide that. That will be provided free of charge. This will count as your CPD requirement. And it will also provide you with research experience, which is something that's compulsory, for example, for first contact practitioner roles or advanced practitioner roles within the NHS. So it's potentially expanding career opportunities. It'll also mean you're working with other osteopaths, both locally and nationally. So it's helping to provide a community and a learning environment of like-minded clinicians where you can share knowledge, share experience. And often this is creating connections that are sometimes not present in a profession which can often be isolating, like osteopathy. So how will it benefit osteopathy as a profession? Well, the research topics are jointly determined by the PBRN members, so the osteopaths, and the organisation NCOR. So you get to have a say in what we're actually researching. So we would rely on you, the PBR members, to identify the research which is of high value to you as clinicians and the research questions you have that need answering. And we then, in partnership with you, develop appropriate research studies to answer those questions, which we conduct either with you or in your clinics or with your patients. It means that the uniqueness of osteopathy, the idiosyncrasies of osteopathy can be catered for because we're not trying to conduct the research in a separate location with a different setting and different clinicians and then try and sort of match it to osteopathic practice. We're actually conducting the research in osteopathic practice. So the findings will be much more relevant and they will have taken into consideration the subtleties of how different osteopaths practice differently and use different approaches, etc. And this gives us these representative findings that we need in order to be able to apply the research to our own osteopathic care. So how will it benefit our patients? One of the things the PBRN does is it facilitates the patient's voice in research. And this is something that's increasingly important in research, is enabling the patient to have a say in research design and the topics of research and how research is delivered and disseminated. And because the research is conducted at a local level in community-based clinics, such as your own clinic, it's much easier to access the patients and get their opinions on how the research should be conducted. And this tends to result in much higher quality research because the patient, which is ultimately the goal of the research, has been involved right from the start, rather than just being a participant in the research study. It also means we can include a wide range of participant types, often in larger studies in specialist care centres or hospitals. The patients involved in the studies often aren't representative of the actual community populations, whereas when you conduct the research in the community, in those sort of primary care settings like an osteopathic clinic, the demographics of the patients are exactly representative of those populations. So it means that the results can be generalized to your patients much more accurately. So it's person-centered, it's real world, and it improves your clinical decision-making so you can make decisions more confidently based on the results. This will improve your patient care, improve your patient safety, and improve patient satisfaction ultimately. So where have PBRNs come from? So it can be originally attributed to a group of doctors, a group of general practitioners back in the 1800s, one of which called Sir James Mackenzie. And he made this interesting quote: "I'd not been long in practice when I discovered how defective was my knowledge. I left college under the impression that every patient's condition could be diagnosed. For some years, I thought that this inability to diagnose my patients' complaints was due to personal defects, but gradually, through consultations and other ways, I came to recognize that the kind of information I wanted did not exist." So ultimately, what James Mackenzie and a group of other GPs had identified was that there was a gap. There was a gap in the knowledge. They didn't have the knowledge they needed in order to diagnose these patients. And initially, he thought that was his own personal deficit, that he was unable to diagnose his patients, but ultimately came to realize that actually just that knowledge didn't exist and they needed to gather that knowledge. And so the way they did that was by using their patients' records and starting to conduct small-scale studies within their general practices. But I particularly like this quote because I think it's something that resonates with my journey in osteopathy, and something that I hear a lot from other osteopaths is that, often when you graduate, and certainly when I graduated, I thought I was hot stuff. I thought I was going to be able to diagnose everybody and fix everybody because I was so good. And then after graduating, when lots of your patients don't get better, you start to realize, well, is it that I'm not very good at osteopathy? Am I not a very good osteopath? Or you start to think, is it that osteopathy is not very good, and that's why the patients aren't getting better? And so I think often there's that insecurity around clinical practice. And for me, it was very much accessing research and accessing more information that was that salvation and rescued me from that insecurity, because it made me realize it wasn't my inability or weaknesses within osteopathy. It was just this lack of knowledge. We just didn't have that information, and I needed to, or we needed to, find that as a profession and just as in healthcare generally. So I think this is something that's quite nicely identified by something called the Dunning-Kruger journey, which I'll come back to later. And I think it's an issue that we have in healthcare, but in osteopathy particularly. And I think the PBRN may be a way in which we can start to address this, which will particularly help our more junior colleagues. But I'll come back to that. So PBRNs as a concept have existed for a long time. They originally were developed in medicine and general practice, but they exist for pretty much all professions. So there are dental PBRNs, there are PBRNs in complementary medicine, but there are lots of PBRNs in osteopathy, and there are lots of PBRNs in chiropractic, but none in the UK so far. So there's particularly successful PBRNs for osteopathy and chiropractic in Australia and New Zealand, so the Orion and the Orc NZ, and they've been up and running for a while and conducting studies. Similarly for chiropractic in Denmark and the US. And there's a new PBRN for chiropractic, amusingly called Crunch, in the UK, but that's quite a new project. So the PBRN we're proposing for osteopathy would be the first of its kind in the UK. So why do we need a PBRN? So ultimately, research improves our understanding, it improves our knowledge base, it informs our decision making, and this improves our patient care. There's an expectation from patients that osteopaths will practice in accordance with evidence base. So while our patients may not necessarily be coming in and asking us what's the most evidence-based treatment for my back pain, they will be assuming that the treatment you're providing has some sort of foundation in evidence and has been to some extent tried and tested, and that you're not just kind of making it up as you go along. And patients have that expectation from healthcare generally. So it is something that, while not necessarily discussed by patients, there is kind of this tacit understanding that the treatments have some sort of foundation in evidence. That comes from the regulator. So it's in the rules, it's in the OPS. We have to practice in accordance with the evidence base. It comes from patients and from the public generally, but also from other osteopaths. We want to maintain high standards. We want osteopathy to be respected. And so we want to be providing the safest and most effective care that we can for our patients. Other healthcare practitioners will expect us to be using evidence-based treatments. Certainly, if they're wanting to refer patients to us, they'll want to know that our patients are getting the safest, most effective care possible. And that generally comes from using an evidence-based approach. There are various threats to the practice of osteopathy currently. Many of these were highlighted in the recent paper, What's Wrong with Osteopathy, which got quite a lot of attention. This is evidenced, though, by reduced recruitment to osteopathic education institutions. Roughly half the numbers this year that they had last year. And there are various factors that are at play here, but ultimately we're approaching sort of zero growth in the profession at the moment, where there's a similar number of people leaving the profession as there are joining the profession. And within a few years' time, we'll actually see the profession go into decline unless something changes. There has been a big push for regulatory reform through the government. So this would be where they actually look to reduce the number of regulators. And so as a small regulator, such as GIOSC, we potentially would be one of the likely candidates to be subject to that regulatory reform. There's a limited career structure within osteopathy. Because of the nature of osteopathy, generally you can graduate as an osteopath and then never really change your career. You just continue to work in practice, whereas within larger organizations such as the NHS, there's generally a career structure. In osteopathy, that suits some people, but for a lot of people, that's a frustration within osteopathy and can be a reason why some people leave the profession, because there isn't that natural progression. This has led to retention issues within osteopathy, where we're seeing particularly a lot of younger osteopaths leave the profession quite early in their career. A lot of osteopaths are looking to work within the NHS. For many of the roles that osteopaths want, such as first contact practitioner or advanced practitioner, research skills are required. And often research isn't a big component of undergraduate education. So there's potentially a gap there that we need to fill to open these roles up to osteopaths. I think research involvement generally will help improve the credibility of osteopathy. And I don't just mean creating research that proves that osteopathy works. I think just the profession being involved more in research will just improve the credibility of the profession amongst other healthcare providers. So thinking about those research skills, just to highlight those for the NHS roles, within the NHS, there are what's called the 4 pillars of advanced practice. So if you're looking to work in any of the more senior clinical roles, which as osteopaths, that tends to be because of the large amount of clinical experience that osteopaths get as undergraduates. When they apply for clinical roles in the NHS, they're tending to look at more senior roles because of that significant clinical experience that they have. But often it's other aspects of those 4 pillars that might be lacking. So potentially the leadership and management or the research usually. So if we look at the research pillars, these are the sort of criteria to fulfill if you're looking at applying for one of these roles under research. And the first one is critically engaging in research activity. So something like a PBRM would provide that opportunity, and it would pretty much provide evidence for all of those criteria if you were to take part in some research being conducted through the PBRM. So what would a PBRM look like in the UK for osteopathy? So there'd be the PBRN coordinator, which is me, and I would work through NCOR and through University College of Osteopathy using their resources to help generate the studies, fund the studies, plan the studies, administrate the studies, etc. But then we would probably have regional coordinators. So these would be osteopaths who have a particular interest in research, possibly have a little bit of experience with research, and they would act as regional coordinators or research champions, they're sometimes referred to, and they would have contact with multiple clinics in their area. So there might be a regional coordinator for Kent and East Sussex, for example, and they would have contact with several clinics in the region. And obviously for each clinic, there'd be multiple osteopaths. And then each of those osteopaths would have lots of patients. And so in this way, the PBRN can have a large geographical area of coverage and potentially a large number of patients from which to generate data which can produce meaningful research. But the burden on each individual regional coordinator, multiple clinic, osteopath and patient is diluted because of that large involvement. So it means that it's not too onerous to do the research. You've not got to hand out millions of consent forms or questionnaires, because ideally lots of people will join the PBRN and undertake some activity. So kind of research that we might do, I mean, ultimately all research potentially falls into two categories, and it always starts with a research question. So we have a question that we need an answer to, and there's two ways in which we can go about answering that question. So the first one is we can look at the data that already exists. So if we think there's enough data in existence, there's enough research already in existence to answer that question, we can analyze it. And this would probably take the form of a systematic review. And so I'll for those who aren't familiar with systematic review, I'm going to talk a little bit more about those later. So that would be one approach. And so that might mean that as a member of the PBRN, you and some other osteopaths form a research team and conduct a systematic review to answer a research question. There was in today's edition of Osteopathy Today, I think Marianne Benison talks about a systematic review that she conducted looking at the effectiveness of manual therapy for knee pain. So that was a systematic review she did for her master's degree a few years ago. And so if you want to read about the experience of doing a systematic review, then you've got Osteopathy Today, then Marianne Benson talks about hers. So if the data doesn't exist, then we have to collect that data before we can analyze it. And so we would have to conduct a research study where we're actually taking or collecting data. And this might be data we collect from your patients, or it might be data we collect from you. It would depend on what the research question was, or maybe both. And so that would be a research study. It might take the form of a survey that we send out to osteopaths or to patients, or it might be we start collecting data from patients using patient-reported outcome measures or PROMs. There are potentially lots and lots of studies. So ultimately, that's how the research would look. So if it was data collection, it might mean you recruiting patients from your clinic, asking them to take part in research, or it might be you completing a survey, providing data for us if we're looking at something to do with clinicians themselves. So I'll just talk about some studies that have been conducted previously by PBRN. So this was the Danish chiropractic PBRN, and this was looking at pain trajectories. So pain trajectory is the patient's reporting of their pain over time. So you can have episodic trajectories, fluctuating trajectories, and persistent trajectories. And so as clinicians, we're interested in patients' trajectories because often different trajectories might need different management strategies. But also, if a patient has an episodic trajectory of pain where they might have a good week and then a bad week and then a good week and a bad week, if we see them for a treatment and then a week later and they come back and their pain's much better, we're probably not going to get too excited about it because we know that's the natural course of their pain, to have good weeks and bad weeks. If, however, they have a persistent trajectory of pain and they report that they've had consistent pain for the last 6 months and they come for us for a treatment and then a week later they feel a lot better, then we're more likely to be giving ourselves a big pat on the back because we've managed to get them better, when the history of their pain tended to suggest that they were generally quite consistently in pain. So pain trajectories are important to us clinically because they help us assess the effectiveness of our treatment, but also certain types of pain patterns might require different treatment interventions. So this study was looking at whether patients can actually report their pain trajectories accurately or not. And so the way it did this was it used PBRN members to recruit patients. And they managed to recruit 719 low back pain patients, which is a lot of patients for a study. That's really good. What they did was they asked those low back pain patients to score their pain weekly on a numerical rating scale. So every week, the patient would be sent a text message and they just had to reply with a number, which was their pain for that week. So it wasn't particularly onerous for the patient. All they had to do was type a number into their phone once a week, 52 times. It wasn't particularly onerous for the osteopaths because all they had to do was ask the patient to take part, and then their job was finished. The osteopath didn't actually have to do anything else after they'd recruited the patient. And if you had 150 osteopaths as members of the PBRN, they'd only have to have recruited 5 patients each to have got 700 patients in the study. So it wasn't too much work because of the structure of the PBRN. So anyway, they recorded these patients' pain trajectories by asking them what their pain was every week for a year. And then at the end of the year, what they did was they asked their patient what they thought their pain trajectory had been for the previous year. So they asked the patient, was your pain fluctuating? It was up and down. Was it episodic, where you'd have a block of pain for a few months, then it would go away for a few months, then it would come back for a few months? Or was it constant? It was just there every day, regardless. And what they found was that the pain trajectory that the patient thought they had bore no resemblance to what they actually reported with their text messages week on week. So the text messages gave a much more accurate, real-time account of what their pain was, whereas reporting their pain trajectory at the end of the year was very much subject to their recall bias and lots of things that affect memory. So while they were pretty good at matching the intensity of the pain and the severity of the pain, there was no match at all to their pain trajectories. So this is just a nice, simple study that just helps us realize that patients' reporting of things like pain trajectories is highly likely to be inaccurate. And so we need to be really careful if we're using that information to make significant decisions about their care. And it might be that we actually need to monitor their pain more regularly than requiring them to just reflect back over a period of time and think about their pain. So this is evidence-based practice. This is informing us that patients' perceptions of their pain trajectory is highly subjective and likely to be inaccurate. So this is just another piece of information that just informs our clinical decision-making. So another study, again, this is a chiropractic one. This one is from America. So this was looking at the issue of the opioid crisis. So opioids account for 48,000 overdose deaths per year. And many of those people will have started taking opioids because of musculoskeletal pain. So one potential way to reduce overdose deaths is to look at non-pharmacological methods of managing musculoskeletal pain. So in the US, chiropractors looked at the insurance data, which is a big advantage of the US system, if you've got insurance, is that all the treatment is recorded for insurance purposes. So you can conduct a retrospective study where you look back in time by pulling up records from the insurance data. So what they did is they looked at everybody who had spinal pain, and then they looked at how many of those people with spinal pain had been prescribed opioids. And then they did a separate search where they looked at people with spinal pain who'd had chiropractic treatment. And then they compared the two searches. And what they found was that people with spinal pain who'd had chiropractic treatment were significantly less likely to have been prescribed opioids. So what they could then extrapolate from that was that potentially chiropractic had a role in reducing opioid prescription by being used as a primary intervention for spinal pain, and potentially has a role in reducing opioid deaths. So again, a really simple study, the advantage being that they had the data already recorded because of the insurance system, but using PBRN members was able to create quite convincing and compelling evidence that chiropractic is an advantage in the management of musculoskeletal pain or spinal pain because of its potential benefits on reducing opioid prescriptions. So that's another example of a PBRN study. So again, this is evidence-based practice, and that is now providing evidence for clinical practice that chiropractic care for spinal pain reduces opioid prescription, which is a good thing. So that's evidence-based practice, or an example of it. So if you just sort of go back to what is evidence-based practice, it might be more helpful to think about it as evidence-informed clinical decision-making, because making clinical decisions is something that you have to do multiple times with your patients every day. And how is it that you're making those decisions? Well, hopefully you're making those decisions based on evidence. Now, when we say evidence, most people think about sort of research evidence that's published in journals, peer-reviewed evidence. And yes, that is one type of evidence, but it's not the only type of evidence that you should be using when you're making your decisions. The reason that published evidence is a good source of evidence is the process of publishing research does as much as it can to reduce the potential for bias in the findings. So hopefully when we're reading research, we're reading the most objective version of that information that we can get. It's less subject to our own biases and our own opinions. So that's why it's a good source, but it's not a perfect source. We also need to use the patient's values and their own circumstances. This is another form of evidence. So it might be that the best published research evidence says that surgery is the best treatment for the patient's condition. That would be an unlikely circumstance, but for argument's sake. However, if the patient has no intention or desire to have surgery, then that treatment is off the table. So it no longer becomes the best treatment for that patient because the patient's value and circumstances that they don't want surgery. So we'd have to look at something else. We also can use our clinical expertise. So this is based on our past experiences with similar patients, with similar conditions, when we've used other treatments and how we think that these might work in the future with other patients and similar conditions. But remembering that a lot of our clinical expertise will be based on best research evidence and patients' values and circumstances from previous encounters. But again, it's how we integrate those different sources of evidence, which is our clinical expertise. And finally, information from the practice and from context generally. So this is just sort of pragmatically what is available. What realistically can this patient have? You know, what can we as a clinic provide if the best research evidence says one treatment, but we just can't provide that treatment? We need to have a conversation with the patient and say, well, we can do this instead. You know, how do you feel about that? Or we can look at, you know, providing the treatment for you elsewhere. So it's considering all these different things and then having a conversation often with the patient about what they want to do. It's not just imposing what the evidence says or what we think is best for the patient. It's about trying to integrate all these different sources of evidence with the patient, shared decision making, to come up with a management plan. But often you're sort of faced with this predicament. It's what the evidence says and what the patient wants are two very different things. We've all been there when the patients come in and said, "Oh, my disc has clicked out of place. I just needed to click it back in again." And you're left thinking, "Well, I know that's not what's happened to you, because that can't happen. But I know that if I do that, you probably will feel better, but for reasons other than you think." So you're sort of faced with, do I have a very challenging conversation with you where I challenge a lot of your beliefs and things that have been said to you previously by people that you probably trust? Or do I just do what you want, knowing that it probably isn't going to do any harm and it probably is going to make you feel better? So there are challenges with using evidence-based practice, definitely. So how should we use evidence-based practice? Well, there are 5 A's that we have to follow. So ultimately, we need to make a clinical decision for a patient. We can ask, and so we need to convert that clinical decision into a question so that we can identify where the knowledge gap is. So this might be a question that we can answer with a quick search on the internet to find a relevant research paper. It might be something that requires a systematic review. It might be something that requires an entire randomized controlled trial. There'll be different levels of question. It might be a question that you're going to answer yourself in a coffee break. It might be something that we're going to answer as a PBRN. But ultimately, a question has to be formed, which will probe that gap in the knowledge. We then need to acquire the knowledge. So we need to collect the best evidence. That could be asking the patient about their values and beliefs about a set of treatments that you've offered. It could be looking up a systematic review that's of a similar topic. It could be having to conduct a study. But there'll be different scales of acquiring that knowledge. We then have to appraise that evidence. So if it's the patient's values and beliefs, were they adequately informed beforehand in order to make a decision? If we're reading some research, is that research applicable to our circumstances? Does the research have good rigor and quality? Can we generalize it to our situation? Once we've appraised that information and decided it's suitable, we then need to apply it to our situation, and we need to integrate it into our clinical decision making. So we need to integrate that research paper we've read. We need to integrate the patient's values and beliefs. We need to integrate our experience and expertise, and then we need to pragmatically look at what can be achieved in the clinical context and setting that we're working in. Once we've done all that and we've implemented that decision, we then need to audit it or appraise it, and we need to audit it and essentially see whether it had the outcome we were looking for. Did it improve patient care? Did we achieve a good outcome? If not, what do we need to do differently next time? And so this cyclical process goes on, which is what allows healthcare to evolve and continually improve. We don't just do the same thing over and over again. We're constantly looking to see if we can improve it with this process of of constant audit and data acquisition and evaluation. So that's the sort of theory of how to implement evidence-based practice. Why is evidence-based practice important? Ultimately, it's going to provide the safest treatment for our patients, because when we're auditing it, we'll be looking at things like side effects, adverse effects. It's hopefully going to provide the most reliable treatment. So what that means is the treatment that's going to work for the most patients, because just because it worked for one patient doesn't mean that same treatment will work for lots of other patients with the same complaint. We want the treatment to be the most effective. We want it to get the patient better the quickest and to keep the patient better for the longest. We want the healthcare to continue evolving. So we want treatments to get better all the time. We want the treatment we're providing in 5 years' time to be better, safer, more effective than the treatment we're providing now. And it's not going to do that if we just keep doing the same thing without questioning it. We want to include the patient's voice because we know that'll lead to better outcomes for the patient. And evidence-based practice as an approach just promotes inquiry and reflection. It promotes us being critical of ourselves, which generally will facilitate us being better and trying to strive to be better. So I'm going to go back to the Dunning-Kruger journey. Something I think certainly resonates with me, and I think a lot of people I've spoken to. So this is essentially the balance between confidence and competence. So if we look at this, if we look at the start of the graph, so this is the journey, this arrow. I'm pointing at my slide here, and I'm thinking you probably can't actually see me pointing. Let me just, there we go. So I got my laser pointer. Hopefully you can all see that now. So this is the journey, essentially, when I keep talking about this journey. So when we start off in our clinical careers, often we have a lot of confidence. So our confidence is very high because we've probably not been challenged too much in clinical practice yet. We're a new graduate. So our confidence is very high. We've passed all our exams. Everything's telling us we know what we're doing and things are good. But in reality, that's probably when our competence is actually at its lowest. So we're a little bit naive to the challenges of clinical practice, and there's a perception that maybe we think things are easy. But very quickly, when you're exposed to clinical practice, you start to realize that actually this is very difficult. It's a very challenging environment to work in. And so your confidence starts to plummet. But actually, that process is already improving your competence. But because your confidence has taken a real knock, even though you're actually more competent, you can often feel like you're doing worse. And so this is where your patients aren't getting better. Is it me? Is it osteopathy? I don't really know what's happening. And I think this is an issue for many osteopaths, and potentially the reason that a lot of the younger early career osteopaths are leaving the profession is because at this point, there isn't that support network of colleagues or a large organization that you're working for to help bring your confidence back up. So you're really kind of left to your own devices to just sort of struggle through. And if you are able to struggle through, you'll learn from your mistakes, your competence will improve. As your competence improves, your results with patients get better, and that starts to build your confidence. And so you feel like you're getting the hang of it, and you're on that learning journey again, and you have to start learning all over again in the real world of clinical practice. But getting past this sort of slump here can be really challenging. And for me, this is where starting to access research became really useful, because it started to give me the answers that helped me realize that it wasn't me, it wasn't osteopathy. It's just that's what clinical practice is like. It's full of uncertainty and it's full of challenges. But it's important to recognize this, because if you don't, there's a danger. Let me get rid of my pointer. There's a danger that if you're not sort of aware of this, you can make decisions quickly because you just trust in your instinct, and you'll just apply the same logic to all decisions, because you're not evaluating and auditing that process of the 5 A's. Often you don't take criticism well because you're not able to sort of self-reflect or self-criticize. and there's a risk that you sort of remain in this overconfident but undercompetent phase where you think you've already mastered everything because you're not aware of that deficit in your competence. And this is where the originator of the PBRNs was. He sort of thought it was him, but actually came to realize it was just the lack of information. But I do think that we've perhaps got something we can bring to the profession. And the more experienced osteopaths will have a lot that the younger osteopaths can learn from, and the research can facilitate that. So when we're at this point here and we're confident, but potentially our competence is at its lowest point because we're new graduates, for example, there is a risk that we don't think evidence-based practice is relevant to us because we already know everything. So why would we need to continue searching out more information and evaluating it and auditing it because we've just been taught everything? But we don't want to just rely on face value and intuition and student education, because that's very subjective. It's very vulnerable to our own biases, things like confirmation bias. We can't rely on our student education because that's going to become outdated over time. So we need to continue updating it, evaluating it, and learning new things. Intuition is very often incorrect. And no matter how good your intuition is, we can't teach intuition to our new graduates. It's not really reproducible. We need to be able to teach them something a bit more concrete and let them develop that intuition naturally through clinical experience. So we need something that's more teachable for undergraduate education. And that's where research comes in, really, because it's got a foundation in reproducibility. That's ultimately what science is, reproducibility. Evidence-based practice is not perfect, though, far from it. There's a real division between clinicians and academics, and clinicians want to focus on clinical practice, and they don't necessarily see that they have a role in research or academia. And so this is what we're hoping to bridge the gap with the Practice-Based Research Network, is take the experience and skills of clinicians, but give them the research support they need to be involved in research. Ultimately, access to research is limited. I mean, you have to pay for half of it. It's like $40 to read a research paper. So that's always going to be a barrier to accessing good research. You need skills to appraise it. It's difficult to understand and apply because it's often not relevant to your clinical setting. And you may not have had the training necessary as an undergraduate. And ultimately, we're all very busy in clinical practice. When are you supposed to fit reading all that research in? There isn't always time. Again, this is what we're hoping to address with the PBRN. So as a clinician, there's all these barriers to research, and the research is really useful stuff. You've got RCTs, systematic reviews. There are treatment guidelines being published all the time. There are masterclasses in certain conditions, evidence summaries for certain pathologies. There are Cochrane reviews, which are high quality systematic reviews. There's big data studies, which are really useful, diagnostic criteria with sensitivity and specificity ratings, as well as patient-reported outcome measures, which are validated ways of collecting data from your patients, prognostic indicators, which give really useful information to patients. But between you and all of that is potentially a paywall where you've got to pay for accessing it. There's your lack of time, potentially not being able to appraise the skills, potentially a lack of competence or overconfidence, meaning you're not really stimulated to look at the research in the first place. It's difficult to interpret, and oftentimes it's just not relevant. So I just want to whiz through some types of research that can be really useful in clinical practice before I finish with how to join the PBRN. So this is an example of a PROM. This is the patient-reported outcome measure. This is called the MSKHQ. This was developed by the same team at Keele University as the StartBack questionnaire, which you may have heard of, is a fairly well-known one. But this is essentially a validated questionnaire that can be used to measure the impact of a musculoskeletal health problem on a patient. You may have heard of other similar PROMs like the SPADI, which is for shoulders. There's the Oswestry Disability Index. There's various PROMs for hip pain, knee pain, etc. The advantage of this one is you can give it to a patient with any kind of musculoskeletal problem. So you don't have to find the relevant PROM for their type of pain. And what it does is it collects data about the impact of their health problem in a validated way, meaning that you can reliably compare the results between patients and between the same patient on different dates. And so it's the kind of thing we would use in research when we want to produce validated results. But it's equally useful as a clinician if you want to just slightly more accurately measure patients' progress over time. So it's just literally 14 tick box questions can be completed in a minute with a patient, but you can get a really accurate assessment, and it's something that we could use to look at the evidence for effectiveness of osteopathy. If we got osteopaths in the PBRN giving patients this PROMS MSKHQ, and then we measured the change in scores over time, we could produce a nice study with a validated outcome of improvement in musculoskeletal conditions treated by osteopaths. So I talked about systematic reviews earlier and how we might conduct a systematic review as a PBRN. So when you look at the hierarchy of research, systematic reviews sit at the top. So they are the best research, if you like, because they're essentially a collection of randomized controlled trials, which are then assessed for quality and all the data merged together so that you have a much bigger sample, which therefore is less likely to be subject to various biases and inaccuracies. So that's a systematic review. So it's a very high level overview of research, and it's usually used to answer clinical questions. And it'd be great for PBRNs. And the Cochrane Library is a really good resource for accessing systematic reviews, and they're all entirely free and they're all very high quality. And there are various steps you go through to conduct a systematic review, which we could easily provide training for, and you as PBRN members could take part in, and then you'd be ultimately authors of a systematic review that gets published in a journal. So having a look at the Cochrane database, these are some systematic reviews that have been published. So manipulative therapies for infantile colic, interventions treating low back and pelvic pain, manipulation and mobilization for neck pain, manual therapy for rotator cuff disease, exercise and mobilization for carpal tunnel. There's literally hundreds of relevant systematic reviews, both for manual therapy topics, but then for healthcare topics more widely. So efficacy and safety of COVID-19 vaccines. Lots of you will have been asked your opinions about that from patients. And here you can provide some objective, impartial scientific data on COVID-19 vaccine. They give a really nice summary as well. So they give they're generally big documents, but they give a really nice, concise author's conclusion. So this is a systematic review about whether corticosteroids is any good for arthritis in the knee. And ultimately it wasn't. So the injections were found to be essentially no different to placebo. So it gives you an author's conclusion, but it also gives you a nice layperson summary as well. So people who received intra-articular corticosteroids rated their improvement in pain to about 3 on a scale of 0 to 10. People who received the placebo rated their improvement to be about 2 on a scale of 0 to 10. So if you had the steroid injection, you'd be saying your improvement was 3 out of 10. If you had the placebo injection, you'd be saying it was 2 out of 10. So ultimately, the data showed that the corticosteroid injection for knee arthritis was no better than placebo. Another good example of a systematic review is this one, looking at all the different types of musculoskeletal pain and the different interventions for them. So we've got everything from pharmacology, medication, psychosocial interventions, exercise. So exercise therapy, we can see, had the strongest evidence across all types of musculoskeletal pain, whereas manual therapy and surgery had quite limited evidence. But this is where manual therapy was just given in isolation, so wouldn't necessarily be representative of how osteopathic care was given, for example. But these are just useful things to give to patients. Ultimately, even when you reduce manual therapy to its most sort of simplistic form, it still has the same evidence for surgery, but with far fewer side effects and costs and negative issues. So it still remains a good option for the patient. But when you consider that as an osteopath, you're probably going to be using some form of exercise therapy as well. There'll be elements of psychosocial interventions in your management. You'll be giving self-management advice and education as well. You're going to be using almost all of the elements within this systematic review other than the pharmacology and injections. So in combination, your approach is very well evidence-based. So it's about being able to sort of not just see the manual therapy a bit and saying, oh no, that's just not showing any support for osteopathy. When you actually consider how osteopathy works as an intervention, we're taking from all the different aspects that have been shown in this top right hand box here. Get my laser pen. So all these interventions here will probably form a component of many osteopathic interventions. So the links are there for you to have a look at this study. I realize it's a little bit small probably on your screens. This is big data. So this is the Global Burdensome of Disease study. It's a really interesting study. It's the biggest study of its kind. It was funded by the Bill Gates Foundation and essentially looked at the incidence and prevalence of disease throughout the world. But what it did is, rather than just looking at mortality, which is sort of how quickly a disease kills you, they looked at years lived with a disability. So how many years of your life are lost to being disabled in some way because of the disease? So this meant that we could now start to look at diseases that don't really cause death, such as musculoskeletal disorders, and actually compare them to diseases that are traditionally measured by their death rates or mortality. And so this is where the term burdensome comes from, because rather than just looking at the death rates, we're looking at how burdensome that disease is. So how burdensome is it to the individual, because they're having to live more years of their life with a disabling disease? And then how burdensome is it to society more generally, because that disability is impacting their ability to work, their ability to care for their family, their ability to contribute to society, etc. So it measures disease in more sort of real terms. And what you can see is, consistently from 1990 to 2000, the most burdensome disease in the world was musculoskeletal disorders. That's more than mental disorders, more than neurological disorders, more than diabetes, more than cardiovascular disease, respiratory disease, and more than neoplasms. So that's all cancers. So that's the impact of musculoskeletal disorders. We can go a little bit deeper and look at musculoskeletal disorders more specifically. So if I go to the next slide, this is now looking at disease in the West Midlands, so the region where I practice. And we've sort of gone down a category. So what you can see now is that in the top 10 most burdensome diseases in the West Midlands, we've basically got low back pain, number 1, headaches, number 4, falls, number 5, neck pain, number 6, osteoarthritis, number 8, and other musculoskeletal conditions, number 10. So out of the top 10 most burdensome conditions in the West Midlands, and it's pretty much the same for the whole of the UK, 6 of them are potentially amenable to osteopathic management or would come within the scope of practice of osteopathy. So that's 6 out of the top 10 most burdensome diseases. And we're still way above all the other diseases you would typically think of being the worst sort of diseases that should be the focus of healthcare: COPD, asthma, bipolar disorders, and specific cancers and diabetes and things will feature even lower down. So this kind of big data can really reframe where we need to focus our healthcare resources. So going back to PBRNs, they're providing local research at a local level for osteopaths and their patients that's going to be really specific to the community the care is being provided in. it's what's known as this bottom-up approach to research rather than top-down, whereby it's the osteopaths who are deciding on the research topics that are important and are a priority, because ultimately they know what needs to be done, and they're most in touch with patients who know what needs to be done. And it can produce meaningful research, such as the research I showed you conducted in America and Denmark at a comparatively small cost, while building the profession's research skills and developing a community of learning within the profession. So how do you get involved in the PBRN? I mean, the links will be in the PowerPoint. The QR code takes you to the NCOR website, where you can leave your name and email address. And this will then mean that you're on our mailing list to be sent further information about the PBRN. So you just go to the NCOR website and register your interest. The sort of official launch is at the IO conference in a couple of weeks' time, where we'll be trying to get as many people to register their interest as possible. And then within a few months, what we'll be doing is sending everyone who's registered their interest a survey. And this survey will ask lots of questions about you and your clinical practice. And the reason we're doing this is so that we can build up a picture of the sorts of people who are going to be members of the PBRN, so that we can know what kind of research will be feasible. So if we've got people who specialise more in paediatrics, we'll know we can do some research there. We've got people who are working a lot with older patients, we'll know we can do things there. If we've got some people with research skills, we might approach them to be regional coordinators, etc., etc. If you complete that survey and provide your consent, then you're effectively enrolling into the PBRN and you'll be a member of the PBRN. There's still no sort of commitment at that point. Once you're enrolled, though, you'll be able to start to take part in discussions about research. So we'll be looking at what research topics we want to do. And then we'll start to propose some research studies. And it may be that you're invited to take part in a research study. Again, there's no commitment that you have to take part in every research study we do. For many of the research studies, it may just not be appropriate that you take part. If you happen to be a bit busy at that point in the year, there's no obligation to take part, but you are just part of the resource of the PBRN that could take part in studies. And so this might be filling in another questionnaire, it might be trying to recruit patients, it might be taking part in a systematic review or some other research activity, and the necessary training would be provided. And participation is entirely voluntary. You can remain within the PBRN and not have to take part in every study. We've currently started a Facebook page, it's a Facebook group that's part of the NCOR Facebook page called Research Skills Training. And so there's various modules that you can work through which look at different aspects of research. So there's some activities about Cochrane reviews. There's some activities about the big data with the global burden of disease study. There's some activities about using proms, with a few different proms you can try. So you kind of work through them as modules. There's some videos to watch where I do a little lecture, or there might be a website to visit, or other different activities. So it just gives you a little bit of a taster of the kind of training and involvement that being a member of the PBRN might include. That's pretty much me finished. So I'd be really interested to hear your thoughts on the concept of a PBRN generally, how much of a priority you think it is, if you think there's any real obstacles to involvement that we perhaps need to have a think about how we can help people overcome that, what perhaps has made you interested, if you are thinking that that's a good idea, and whether you would be prepared to get involved. So as I say, there's the Research Skills Training Group, there's a link there. We're on Twitter, Facebook, and Instagram, so there'll be updates about what's happening with the social media. But the best thing to do is to leave your email address at the website, and then you can get emails directly about any updates, and then you'll receive the survey at a later date. So thank you very much for staying with me.